All right. Well, it's noon. Thank you, everyone, for joining us in this 2022 Telemedicine Project Echo series. Dr. George, good afternoon. This is also part of the grand rounds of our internal medicine, Department of Internal Medicine. So the other room there are our colleagues from internal medicine. And Dr. George last week did an excellent presentation on telenephrology. Dr. George?
Yes, hi, hello. I welcome both the speakers for today. Dr. Santos, you're taking the...
Dr. George, can you hear me?
Yes.
All right. Well, today we have another exciting topic. Thank you very much, Dr. Sarah, for making this happen. This time it is about telehealth and related technologies to help patients quit smoking, vaping, and quitting tobacco products. We have special guests, Dr. Dayan Beneventi and Dr. Karam of the world-famous UT MD Anderson, and Sarah Tello, our local expert in smoking cessation here at TTUHSC. We also have here our leader of telemedicine student interest group, Adrian. Adrian?
Hey everyone, I'm Adrian. I'm the treasurer for the telemedicine interest group. And this educational activity is a project of TexLa Telehealth Resource Center, a federally funded program with F. Mary Hall Rural and Community Health at TTUHSC, as well as Well Ahead Louisiana, with generous support from Health Resources and Services Administration, or HRSA.
All right, to introduce our next slide, to introduce our presenters, Sarah.
I'm Sarah Tello.
Next slide.
I'm a certified, nationally certified tobacco treatment specialist, but I attained my original certification at MD Anderson and met these two wonderful people. And we would not have this program here if it did not start at MD Anderson. And I fell in love with helping smokers. So I am so incredibly grateful for these two and for MD Anderson. Right.
All right, yes.
We have with us Dr. Dayan Beneventi. She's an assistant professor in the Department of Behavioral Science and the clinical director of tobacco treatment program at MD Anderson. She has over 10 years of experience in tobacco treatment. She's been a licensed clinical psychologist for over 20 years and is currently licensed in Texas and Louisiana. She's a certified tobacco treatment specialist and helped create the Certified Tobacco Treatment Specialist program at MD Anderson. She also supports and participates in Project Teach, a telementoring program for cessation. Dr. Haig is a professor of psychiatry at the Departments of Behavioral Science and of Psychiatry, and he's the founding medical director of the tobacco treatment program at University of Texas MD Anderson Cancer Center. He is the PI for more than 25 clinical trials and president of the Association for the Treatment of Tobacco Use and Dependence, and lead faculty and course director of MD Anderson Training Program for Tobacco Treatment Specialists.
All right, next slide. We will probably ask Dr. Beneventi to share their slide.
Great. So, well, thank you all for a wonderful presentation, for the invitation also to be here with you. Both Dr. Beneventi and myself will be actually walking through a couple of things here with you today. The first one, really, as you see there in the outline, we're going to talk a little bit about some background about what is this business of tobacco and smoking, what impact it has. Then we'll try to address a little bit the digital technologies that gets into, in our medium, how we could use them basically to enhance our reach. And of course, telehealth is one particular one. And then we'll talk a bit about treatments. Hopefully we'll have time for questions at the end. And so let's start with some background. And you all probably know, but in case it's not clear, there's almost 500,000 people every year die from smoking, related illnesses in this country alone, and about 5 or 6 million around the world. And if you look at this graph, it really sort of summarizes the major diseases that leads to death eventually from tobacco. And as you see on the top right hand, the lung cancer is about 30%. Under that, you see ischemic heart disease, about 30%, and then COPD, another 20%. And then, of course, other diagnosis about 10%, and the rest is stroke and other cancers. So in other words, 90% of death and disease from tobacco can be summarized into cancer, COPD, or cardiovascular illnesses. And so that's important to just keep it as easy reference in our mind. And this does not go unnoticed as far as the cost of healthcare. Just the cost of healthcare is 170 billion, in addition to another 150 billion on the economy. So it's not a simple matter. It's not, it's not just about disease, it's also the cost of it to our society. And so the good news is that the smoking rate has declined. Right, so it was really the peak around in the 60s until the first Surgeon General report came out in 64, and that actually from there on, it really, as you see the black line, the solid black line coming down, in males, that is, of course, there are more male smokers than females back then and still today. And then, just the females would be the next one, that is the dotted line also in black. These are the former smokers. It's declining. It's sort of steadied at some points there now, but it's good. It's good that we have. I'm sorry, I misspoke here. The current smokers is declining. Of course, the former smokers is going up in both categories. Next, and. Did I?
There we go. Sorry, I got hung up.
Okay. All right, Dr. Benavente is advancing a slide here to simplify this. And so today we have about almost 14% of our adults are smokers. That's a lot of people. I mean, 34 million, or more, depending on how you count the population. Right? And the other thing that is important to keep always in mind is that psychiatric comorbidities are always a problem in terms of making it harder for people to quit smoking. As you see in this graph from SAMHSA, that from 2008 to 2018, in that 10-year span, both the smoking and people with no behavioral health condition, meaning general population, has declined from about 21% to about 15%. But also, smoking among a mental illness or patients who have mental illness have declined, but it still is double those who don't have mental illness. So that's the dilemma. This is where, where we see that there is something going on there that really keeps this being alive, if you wish, or more difficult for patients with mental illness. Okay. And now, in reality, the best treatment that we could offer is medication and therapy, meaning counseling. And as you see in this graph on the left hand, we start with the people who are interested in quitting smoking. 70% in 2000 said they were, and it kind of continued to be steady around throughout the years until 2015. We don't have the 2020 yet, but hopefully soon we'll have that. The point here is that a lot of people, really almost everybody, wants to quit smoking. And so we don't need to be shy or too careful in suggesting that they ought to quit smoking. And as you see, the next group of columns is about people who have made a quit attempt in the prior year. About half or more have tried to quit, and only about 7% managed to quit. That's the next group of columns that you see there. And there's some good and some bad news there. The good news is that 60% get some advice from their provider to quit. The not so good news is that, about a third would get only either behavioral counseling or medications or both. When you separate the two, which is what we want to have as the standard of care, the best way really to help people is having both. That ends up being just 5% of patients getting both. it is tremendously low. It is really, a huge area that one can make a big impact in. And this is actually, we're talking about just basic medication, the standard medication for tobacco and the standard counseling, let alone advanced strategies that we sometimes do. So next. And so the other important part is that people can try on their own, as you see in this slide. People who bought, this is from England, the people who bought the NRTs, nicotine replacement therapies, over the counter. And you see the odds ratio for them to quit is just the same as doing, nothing or taking placebo. It's just 1. Then if they did get a prescription from a healthcare provider with a brief advice, that gets a little bit better. So we're talking 1.5 or close to 2. But then if they got the medication and got specialized behavioral support, meaning somebody who knows about tobacco and knows how to help them, then we're reaching above 3, the odds ratio. That means 3 times better than doing it on your own or taking just nothing, right? Or placebo. And so that's important. And that's why we actually have a course that we do every 3 months or so and train providers and to know those particular things about tobacco that we don't really get trained in the healthcare setting. And so if anyone's interested, at the end, we'll show you some a slide that's, how you could get trained, actually, if you want to, if you're interested.
Okay, I'm
All
going to
right.
take over
Go
now
ahead, Nan. Yes.
after Dr. Karam. We're going to talk about additional technologies and ways that people are helping bridge that gap. As Dr. Karam mentioned, for a few years now, the tobacco treatment community has been promoting an initiative to try to encourage more healthcare providers to provide that integrated care with medication and also follow-up counseling. The reasoning behind that is that's the most frequent interface that patients have is with their medical providers. And so it seemed to make sense that that should be the place where this takes place. However, well-meaning doctors are also very busy, have limited time. And as you might imagine, the patients come in and they're not particularly interested always in talking about tobacco. They've come with some other presenting concern. Despite this, it has been shown that interventions, even less than 3-minute interventions from medical providers, do increase quit attempts and abstinence. But in terms of doing the fuller treatment that Dr. Karam was talking about with medication and behavior specialist support, it turns out to be kind of impractical for doctors. They don't necessarily have the time. Also, the billing codes are confusing. There's a lot of different billing codes, and there's different documentation requirements that pertain to each code, like a consultation versus a follow-up. You have to have very different documentation in order to get reimbursement. So sometimes reimbursements are denied. And even when they are paid, unfortunately, it's paid at a fairly low level, which is just a natural disincentive for doctors to be doing that. Although that is all true, as he pointed out in the previous slide, over 60% of physicians are recommending to their patients that they quit, and that is having an impact. Some of these practitioners are utilizing the ever-developing world of digital technologies to further extend care to their patients and to give them a way to take a more active role in it after the appointment. Some of them are really quite good. Smokefree.gov, if you ever wanted to take a look, that's a really good example of an internet site that gives people an ability to make their own quit plan, lots of self-help, lots of advice. And they also, on the smokefree.gov, have an option to get an interactive texting from them called Smokefree Text. And what's kind of special about this texting program is that they have different groups. So they have for pregnant mothers, for teens, for veterans. And so these are more personalized texting programs. And that's shown to be more useful than a more generic kind of way of going about it. Again, another good example of a focused application is Quit to Heal. It was for cancer patients, and it had a lot of information about how quitting smoking helps with cancer treatment and encouraging messages. That was shown to be fairly highly effective. And then finally, interactive voice recordings can be used by practitioners to extend treatment. For an example, somebody would see the study that was done on this by Rigatti. She had the practitioner go to see the patients in the hospital and have a one-on-one with them. And then the IVR would follow so that patients could ask to speak to a nurse later if they had questions or any kind of follow-up, and they were provided with NRT in the hospital. So that's another way of extending the treatment. The reason for all of this is to try to find some kind of low-cost way to provide the service, because even though insurance it's supposed to cover all the FDA-approved medications and counseling, there just aren't very many programs that are designed just for that, where everything is integrated into one. So for a patient to really get completely evidence-based integrated care, sometimes they're left to their own devices to kind of get the medicine over here, call the quit line, or get the medicine and then do a texting program or somehow put it together. But they also need to be advised that that's incredibly helpful. So the way these extenders, these digital technologies are the most effective if they're implemented is that they should be interactive. They're better when they're digital or individually tailored. And if they're based on well-established clinical practice guidelines and evidence-based counseling, things like acceptance and commitment therapy, for example, there are some apps that utilize that have shown to be really effective. I'm going to move on to the next, probably most promising type of technology for fully integrated care coming to patients, and that's telehealth. And one example of fully integrated care available to everyone is the quit line. And almost every state has a funded quit line. And it is, you get it to, anyone can call and you get up to 2 quits per year. That they have multi-call proactive counseling. And they do provide NRT, nicotine replacement therapies, to at least half. In Texas, it's different per state. Every state funds their quit lines very differently, from like 2 million to 20 million per year. So depends on the state, but they do, most of them do provide at least some nicotine replacement therapy. They've shown to be very effective, as Dr. Karam was saying. Only about 7% of people quit in any given year who make a quit attempt. But the quit line has shown that they can increase that to about 28% when they're utilizing this integrated care. As I said, many of them are underfunded though. So for example, in the Texas quit line, you have to be one of these categories here to get medication: pregnant with a physician's permission, because they don't usually use medicine with women who are pregnant, or you have to be referred by a healthcare provider, reside within a certain community within Texas, or be an employee with a chronic condition or a mental health condition, or completely uninsured. The idea between that is you have slim resources, so let's give them to people who have no insurance. Problem is, people have insurance, but they don't have a program that they can just go to and utilize it. As I said, they can go to their practitioner and maybe get medication, but does that practitioner really have the ability to follow up with them and provide them behavioral support? So we at MD Anderson wanted to see if we did a pilot and said, well, what if we just took that platform, the QuitLine platform, which is democratized, available, fairly efficient, cost-effective, and just improved it just a little bit with some of the things that we know help people quit. We wanted to do that, and we wanted to create a vehicle that maybe we could disseminate this treatment to more people in the community, particularly the underserved members of our community. There's 2 things that we focused on: engage to increase abstinence. One of them is engagement. The Ask, Advise, Connect clinical trial noted below was one of our colleagues actually started it, and it was focusing on the safety net clinics in the Houston area, the most underserved, generally underinsured or uninsured people who have multiple comorbid disorders. We know these people are harder to engage and to have success in quitting. And they did a study, and they found that people who completed 3 or more sessions were 4 times as likely to be abstinent. So keeping people engaged in the counseling, that is one thing that really helps people quit. Another thing that really helps people quit is getting nicotine replacement therapy. Of course, all the medicines, all the FDA approved medicines, you could say the same for them, but generally NRTs are used because they're less expensive and can sometimes be provided without a prescription. So the other thing they found that people were 1.8 more times more likely to quit if they were provided with nicotine replacement therapy. So the Ask, Advise, Connect clinical trial utilizes the Texas quit line. So they had people proactively reach out to these patients, but whether or not they got NRT was dependent upon whether they fit those criteria that I just previously pointed out. So in this study, about 56% of the participants actually got a 2-week supply of NRT. So again, that was, one of the things that limited their ability to impact patients. So those are the two things we focused on in the quit line: increasing engagement and increasing provision of medication. We also used tobacco treatment specialists. We wanted to provide more of a connection for patients. So we have continuity between the intake all through the counseling. You get the same counselor. You don't have an intake counselor and then get shuffled off to someone else. The other thing is we do the intake and the quit plan at the same time. So if you stick it through the first time, the people are getting a month's worth of prescription of NRT, dual NRT, right from the get-go. We incorporated many of the things that other quit lines do, interpretation services. We unmasked our number, because how you get random phone calls and you're like, I'm not picking that up. I don't know who that is. We gave them a flyer with our phone number, and then that number will show up on their phone so they know who's calling. That helped a lot. We enlisted a third-party vendor to send the medications right to their homes. And like I said, we increased the NRT substantially from 2 weeks, what the Texas Quit Line did, to 4 weeks if you do the quit plan. Then if you remain engaged after the first month, we'll send you another 4 weeks. So up to 8 weeks of dual nicotine replacement therapy. And here's our outcome data as of this point. On the right-hand side here, you see the Ask, Advise, Connect data from the study that was done in the same clinics. So the same basic area. Let me just point out that the quit rates for this population are generally lower than quit rates for regular quit lines because of the things I mentioned: underinsured, underprivileged, generally with multiple comorbidities in the safety clinics. So our enrollment was quite a bit improved on the quit line, the MD Anderson quit line, 32% versus the 25%. So that's, of all the people that were proactively called, the percent that engaged and signed up. 95% of our patients received NRT versus 56 during the study that I referenced. 53% of them got an additional 4 weeks of NRT, and that's not available in the Texas Quit Line. And our average counseling calls were 4. So we doubled the engagement compared to the Ask, Advise, Connect trial, which utilized regular quit line protocol. And our abstinence rate was 38% better in this population than the abstinence rate that they got through the study. So really increasing engagement and medication does prove out to improve abstinence and engagement. So just went over that, just reiterating that's what we think the recipe for success is there. And then finally, I'm going to quickly review some data on the tobacco treatment program. That's the program that Dr. Karam and I work in, and he was the founding medical director of. They based the whole program on the evidence from the practice guidelines to be a very comprehensive program for our cancer patients. It's free for all of our patients at MD Anderson, so everything is in one shop, and it's medication, behavioral support, and also psychiatric care if you need it from our doctors. And all of that is provided at absolutely no charge. And the reason that our institution supports it is because cancer patients who are diagnosed and quit smoking have anywhere from a 33 to 45% chance, better chance of surviving their cancer. And they absolutely have better outcomes in terms of surgery recovery, fewer side effects, things of that sort. So when we started, the program was started in 2006, but about 10 years ago, we were trying to find a way to make it easier for patients to access our service. We're in the main campus in the center of Houston, but people come from all over Texas to MD Anderson. And so we started trying to offer a remote service via several telecommunication platforms, SABA and Polycom. We had lots of difficulties with that. There were a lot of technical issues that came up. It was kind of a barrier for us and for the patients. We also had them coming out to the various, let's see if my next slide shows it. Yeah, see the little outposts here. We have the medical center in the middle, and then we have all these other Houston area locations that the patients could come to. And they'd sit there and would put them in front of a monitor, and then someone would check them in and stuff, but then the people doing the service were still in the Texas Medical Center. That was the hub. So it was telehealth, but they still had to go out of their home and drive to the place and get an appointment and all that. In 2019, with the advent of Zoom, we started a pilot even before the institution took on Zoom. We got our own license and we started doing telehealth right to patients' homes. And there were still some barriers with that. There was a learning curve for the clinicians. There's definitely a learning curve for a lot of our patients. Our patients tend to be 55 plus, and not a lot of them were super familiar with the technology or weren't even welcoming that particularly. But the latest phase was since March 2020, of course, was when the advent of the COVID pandemic. And we went 100% remote. Thank goodness we had been working this pilot for quite a while to try to get people ready, because we went remote very quickly. And we also were the beneficiaries of the Texas medical ruling allowing the doctors to establish patient care over the phone. That wasn't allowed prior to COVID. So now we could do a full consult either via video or via the phone for patients. Let's see if I missed anything back there. Yeah. So Zoom was a big game changer for us. It seems to work seamlessly across platforms, Windows, Android, or tablets. It's HIPAA compliant. It's secure servers, and it allows IT to manage the account settings. It's very reliable, straightforward interface, and it improved the user experience for the counselors, the clinicians, and also for our patients. This is a poster that was presented that Dr. Karam and some students he was working with put out. And the long and the short of this is that we looked at the video conferencing that we were doing in the Houston area locations versus our inpatient treatment at MD Anderson to compare them, same timeline, but to compare the abstinence rates. The top little bar graph over here is our respondent only. It's our respondent only. So that means anyone that we treated, we phoned them up, and if they answer the phone and give us the data, that we consider them respondent only. The bottom graph is intent to treat, which is anyone that signed up, whether they picked up our phone or not, we have them in the graph. So if someone, we treated them and they just didn't take our call, we count them as smokers. So it's a very, very conservative estimate. And although there is a bit of a difference here, you can see in the graph, actually statistically, there was no difference between the efficacy, the abstinence rates of people who were in the Houston area locations doing it via video versus our in-person. Here's a closer view of those graphs. And as I said, even though there's a little bit of a difference there at the 6 months for the respondent only, it was not statistically significant. So recently, we decided to take a look at, since we've been completely remote since COVID, we took a whole year of data and said, well, what about video versus phone? And I should say that when I say video versus phone, I'm not meaning video all through the treatment. I'm meaning video at the consult with phone follow-up. So that's really the difference. All of them are combined. It's video with phone follow-up, or it's phone consult, phone follow-up. The best thing that happened was that we transitioned everybody. We didn't skip a beat. We actually increased the number of patients that we saw during that year. And we increased the level of safety in terms of sending out our prescriptions, even though we were all remote and not in the office. So here is our data, although I have to move my, my little screen. Okay, so you can see for the year that we looked at, which was 5/1/2020 to 4/30/2021, I believe. Yeah. So we looked at video versus the phone consults, and the 3-month quit rate was almost 4% higher for video, but that is not statistically significant. At the 6-month, we saw the greatest difference, almost like 5% there. And then at the 9-month, though, they were almost exactly the same, and none of them were statistically significant. Also, the age differed a little bit with the people who preferred the phone, and we let the patients select. They're self-selecting into these groups. We did encourage people to use the video because we can see that that is more of a personal connection. Obviously, being one-on-one with someone in person is the best in terms of that human connection. Probably the next best, of course, the video, and then the phone. but it was encouraging for us to see that no matter what the venue, the quit rates, the abstinence rates were about the same, especially when you look further out. All right. So if you're curious about what kind of helped us make this work, our program, the way it works is we proactively, we find from the electronic health record who is smoking, we proactively reach out to them. We have people who are trained in motivational interviewing and tobacco treatment specialists do that outreach. And then they schedule a consultation with the patient. In order to participate, there are some things that they need to do. We have a complete intake where we do validated measures in terms of substance use and mental health issues and symptoms, things like that kind. We require them to fill that out prior to the appointment, which means downloading, getting a link and entering their stuff on their computer at home. We used to do it in the clinic, but we try to encourage people to do that at home now. And if they haven't done it by the time of our appointment, we just started doing it right then if they came to the appointment, because we feel like that information is really, really important. They also have to sign a consent for telehealth, and we ask them to make sure that they're in a secured location for at least an hour to an hour and a half to be able to complete the consultation. We have found that we have to coordinate 3 different teams with each appointment. So there's coordinators that gather data, there's a counselor, and there's a medical team. So making sure to let people in and out of the appointment, putting the patient on hold and in waiting rooms, that is a little bit technical. And this is the way we do it. We have the counselor start it because they're sort of the driver, and they admit the coordinator who gets the initial information. And then they also put the patient in the waiting room and invite the medical provider on in order to consult with them to finish up with the medication at the end. And that seemed to work very well. As this is pointing out, and I made many mistakes because I'm not the most technologically savvy in the group, but we can always kind of fix it. But having one person needs to be the host and make sure that people are coming and going as they should. We found that we assigned a super user, a technically savvy clinician, to kind of be a resource for people. That was really important. And then spending plenty of time in the pre-appointment preparation. We did equipment checks with people, and we would follow up with them if they hadn't done their questionnaires and things. So hopefully when the appointment time comes along, things go along without a hitch. We really feel excited that we were able to offer this during the pandemic, increased options for patients, especially for people who just don't want to deal with technology. The fact that we could do it all over the phone, I'm worried about that going away, but that has helped us increase our reach, and it's kept our quit rates still very high. So we're providing really complete, comprehensive evidence-based care via a telehealth technology now. So that is kind of the best of everything, and except that we aren't in person, but we hope to be back there soon, just for people who would prefer that. But this is what potentially quit lines could do, or fund programs that were better funded could offer this kind of comprehensive service. In the future, MD Anderson has since adopted Zoom themselves, and patients are accessing it via MyChart. We've kept doing it the way we set it up originally, but potentially we will do that. And also, there are some other technologies that might be even easier to use than Zoom, like Doximity, almost like a FaceTime. For doctors use it a lot. That might be something easier, not having to download things and click on, just clicking on links and things. Anything that makes it easier for patients will be an improvement for sure. And that is it. I'm going to hand it now over to Dr. Karen.
Fantastic, Diane. Thanks for going over all that, which has really been a transformation that really happened the last 3 years or so. We were very lucky, as Dan was saying, that we started that process before the pandemic, a whole year before. We didn't anticipate, of course, a pandemic or anything. We're just wanting to try to be close to our patients and help them not to have to drive to the medical center in Houston, because it's kind of complicated, traffic, finding parking and all those things. And so in addition to our patients being cancer patients, and sometimes they may run behind in other appointments or may have, changes in their schedule. And so of course end up moving, our appointments around or canceling them. And so that's what got us to really start that process, as she was showing there. That really was almost the same, if not maybe a little bit better to do sometimes from that poster that we presented, when we do it remotely on the regional care centers. But now that was all remote. As you see, of course, video conference is just going to be a little bit better than the phone, as it's logical. But this is the data that she showed you to support that. Now, when you see this on this graph, I wanted to sort of walk you through what happens and the challenges that somebody can face, with going that direction. And so just bear with me to explain a little bit. So the in-person really are the green color, and the video conference is the blue, and the purplish kind of color is the telephone. And that's actually starting before the pandemic, again, from June 2019 all the way to March 2020, as you see there. And right after that, in April, no more in person. That's when we went fully, remotely, basically. And so just wanted to, show that. And you see in March, actually, in fact, the middle of March is when we went remote. So the in-person dropped by half, right? If we go to the next slide, I have a little bit better, so you see, if you click to the next one, and then it shows up, yeah, here you go. That's so you see, this is exactly like sort of focusing on that particular period. While we were hoping, as you see there, we had, reached 20 and 21 and then 25% almost on Zoom. We're going up basically every month when we're piloting that. What we're hoping is that when we went remote and the pandemic hit and all that, we thought, well, you know what? Fantastic. We're ready. We're just going to now have 100% on Zoom. To our surprise, that didn't happen. Actually, what happened was, as Dan was mentioning, we got this, a waiver from the medical board in the state, of course, federal government, everybody, to prescribe and establish a patient-doctor relationship even on the phone. So the minute that the patients got a whiff of that, and of course our staff, it make it much easier. Everybody wanted to do the phone. You see, almost 90% in April were on the phone, and just 10% on video. And if I have to guess, I would say those were already probably scheduled 2 weeks before, before the pandemic or whatnot. But anyway, and you see, it went down further in May. So then this is what got our attention. Diane and I were like, wait a second, this is not okay, because we want to provide the treatment any way possible, right? Which is, we're very lucky that we got this, waiver to have to prescribe just by talking with people on the phone. Because before that, we had a program that where, if people couldn't come in person, the clinician, the counselor would talk with them on the phone and try to, motivate them to eventually come in person so we could prescribe, or to do on video. And so we're wanting to improve the video, basically, because we know it provides better care. Of course, face-to-face, communicating different than just on the phone. And so we start to, push towards that, removing the obstacles to see what they are, et cetera, with our staff. And so it went back up, as you see there, with the years passing, with the month passing, I should say, towards the end of 2020, we reached now 40% on video, still the majority on the phone. And so you go to the next one, and this is this year. This is January 2021. The graph is different. It's just because we took out we realized that putting in the in-person and with this, histogram is not a good way. So we drew it more of a line. And this one, the in-person, is of course 0 all along. There's just one there in August. I think it was an inpatient person that was seen. And then the video is the red color, and the telephone is the gray. So as you see now, it is almost equal, right? It just kind of goes up and down a little bit. But so we are at a good point. I personally would like us to be 70 or 80% of those consults the first time we see the patient on video, if not 100%, right? Because of the same reason as we were saying, to establish a connection with somebody, especially a therapeutic counseling connection. It's always better to see them and they see you. So it just gives a little bit more. We're all human beings. And so that just, helps with that connection. And that's what we're betting on to be able to support them. And so, but of course, if the choice is nothing versus doing on the phone would be, better than doing nothing. And so
Dr. Karam, sorry to interrupt. That is a very interesting, observation. Do you have a reason why people wants to do audio compared to video, knowing video is better? Do you have explanation for
The
that?
main, yeah, no, I'm glad you asked that because I was gonna say a couple of words. So it reminded me that mostly it's just people, they didn't want to go through the setting up the Zoom or they weren't familiar with it, or they, didn't know their password because, you have to download the Zoom on the App Store and all these kind of little technical things, right? And that's, by the way, I'm glad you asked that, because that's how I got into Doximity, because I found that to be actually much, much straightforward. You don't have to download anything. So what I do actually, in fact, to tell you a little anecdote there, when clinicians sometimes, said whenever the patient needs a psychiatric evaluation, so they set them up with me, and sometimes they say, well, patient didn't want to do video, and I say, fine. What I do, I call them on Doximity and I say, you know what, I'd like to see you and you see me so we can communicate a little bit better. Is it okay if I send you a link? And so that opens up your camera. Almost 90% or 95% will say, yeah, sure. The only few times that they would say no is like because they're in pajamas or whatever, they're not, well kept or something like that. But so that's why sometimes we say, well, Zoom was fantastic, much better than prior versions of other softwares we used, but still had this sort of downloading the software, setting up whatever. Doximity, I think, is the next version of really getting it straightforward, short of doing FaceTime or things like that, because we usually try not to give the patient the clinician's direct phone number. That would be the problem with using like FaceTime that have So I was trying to keep it that way. That's the other good thing about Doximity. Not that we have anything with Doximity or any interest or anything. It's just that that's where things are. Hopefully, we'll have even better things in the future. So, but that goes a long way to say how sometimes small things like this we see be in the way of people doing, what is better for them. All right, and so what else? So we operate remotely, but also we send patients medications in the mail because we want to pay for them. Our program is supported by the tobacco settlement funds, and so we pay for most of the generic medications. We can't afford the Chantix, but we pay like the patch and the bupropion and things like that. Again, and trying to remove any obstacles from in the way to quit smoking. And so traditionally, we've done that for years. Actually, this is not new. But traditionally, we've had sometimes discrepancies between the address that the patient gives us that is in the Epic system versus our own database, because sometimes they change that and they don't tell us. So this graph shows you that how many of those discrepancies we have. For instance, in January of 2020, we had, say, 5 out of 195 meds that were mailed out, right? It's 2%, a very small number, but still, we didn't want to have anything, right? If we can, we want to just have it always straightforward. And that actually came in after setting up like what I call it 3 layers of checks to make sure that, we don't get at a point where we send the medication to somebody else, basically, right? That's the main thing we're trying to avoid. Thankfully, we hadn't had that happen. We had only one time in the whole year of 2020 that the medication went despite all these checks. So what we did, actually, we instituted a 4th layer of checks. So basically what we said, every single person, when they talk with the patient, they always would want to check and ask them, that address, so that we never really would have this issue. And as you see, if you go back, yeah, that one, in the last few months, we had several months that we had 0 actually discrepancy. And then discrepancy meaning when the staff is coming to put the medication in the mail, they compare our database with what's in Epic, and if there's no discrepancy, that's what we're talking about. If there is discrepancy, of course, we stop. We call it, stop the line, and we pick up the phone and call the patient. I mean, I say all that, to give you a sense of what can be done and the level of safety, how far one can go, even that we're operating all remotely, right? So next, let's see. Okay, well, now I wanted to spend some time. I know we wanted to talk mostly about telehealth and all that, but I also wanted to spend some time to tell you about the treatment itself and what it is that we provide. As we were saying earlier, the ideal really is having both medications and behavioral interventions. And so now, the U.S. Preventive Task Force in 2021, they updated their recommendations, and what they find is that even just behavioral intervention on their own will provide you about 76% better than doing nothing or trying to quit on my own, basically. If then the bottom part of the slide is talk about the medications on their own without, extensive counseling. What's the effect of that? And you see the NRTs, nicotine replacements, with minimal counseling, 5 minutes, meaning a provider, see the patient say, hey, this is not good for your health. You ought to quit smoking, set a quit date, basic things, right? And prescribe them medication. You get about 55% across the board, across all NRTs. And that's a single medicine, not really combination of NRTs, which is what we do now. Bupropion, about 64%, and varenicline is about 124% better than placebo. And so the bottom line here is that, you do behavioral intervention alone would work. You do medications alone would work. But then next slide, let's, but then when you add them together, excuse me, and then you get a 83%, improvement, so that's where, and then if you did it really in intensive behavioral intervention, that's another 15%. So that's where the doubling comes from. So what we say, you can use behavioral intervention or medications, but if you use them together, you're doubling the effect of either being done alone. And so that's what the standard of care should be. And this is the website where this recommendation is at on the US Preventive Task Force website, in case you are interested in looking at. If you're not familiar with them, they're a group of scientists basically volunteering their time to review any and all the literature about preventative measures, and so to make it easier on the public to understand really all this studies sometimes conflicting. And so as you see here, they are giving the medication and counseling for tobacco treatment as grade A, the best possible evidence that we could have that it works, and it's really the thing to go. The only exception is women who are pregnant, and we try not to give them medication unless we have to. All right, and then this is just to put all the NRTs in the same table and show you how they stack up, the gum and the patch and the inhaler and nasal spray. They vary in efficacy, and depending on how they're used, they could be better, under certain circumstances or another. The patch and the lozenge together, we find them to be the best combination. Now, it doesn't have to be the lozenge per se, but the way we think about combining NRTs is using the patch plus one of the other ones, right? And the reason I say that is because the patch gives you a steady dose of nicotine all along. It's sitting on the skin all day long. In addition to it, on top of it, we use the other ones that we call episodic. The gum, the lozenge are usually the easier to use, but also can be the inhaler or the nasal spray. Now, in today's world, we don't use a single NRT because they're not effective anymore, because today's smokers are much more dependent on nicotine than 20 and 30 years ago. That's why we always go with the patch plus one of the other ones. And the other thing to say about that Sarah might know very well, is that we tell people to use those episodics on a schedule, not as needed. Unfortunately, as needed, they don't use enough of them and they don't work. So next is this is actually to show you about the electronic cigarettes, Juul in particular, we're picking on here, but it could be any of the pod devices. And you see the levels of nicotine, how high it can be from Juul compared with a cigarette that's in the bloodstream. And then the bottom one, the darker blue, is the average e-cigarette or NRTs. It's the same. The nicotine replacements are similar of that first generation of e-cigarettes, very low level of nicotine. Now that's a double-edged sword. The Juul is, because if you think about it, it could help an adult smoker to switch and reduce their harm. Now, we don't recommend them to do that. We recommend they use medications and therapy because that's the best way to go, zero harm, because electronic cigarettes still have some harm. It's a reduction in the harm, but still not zero harm. But if those who cannot quit, or those who are not willing to quit, then that may be actually a strategy to reduce their harm until they're ready to quit, right? Now, the double-edged sword part of it is for kids and adolescents. They get exposed to this, they get stuck with it because it has such a high level of nicotine. And even adults, actually, that when they switch, sometimes they have a harder time quitting the electronic cigarettes, but at least, again, is less harmful than the full smoking. with the caution on that is not to use them along with smoking. The dual use of electronic cigarettes and smoking is actually worse than smoking. So that's always important to, if you have somebody who's not able to quit or not willing to quit and you want to reduce their harm, make sure they want to try to switch, then not to get stuck with both of them, because that's worse than smoking, apparently, for the respiratory health at least. And that's how the patch looks like. This is the Nicoderm CQ. And that's how the Nicorette mini lozenge looks like. This is the bupropion. That's the other medicine that we use. Zyban is the name, or Wellbutrin. And that's the efficacy of Wellbutrin is actually 64% better than placebo. These are all the studies that were done, on that medicine. And this is from the Cochrane database. And so just to show you that plenty of studies, and that's the net result of when you put them all together, right? Varenicline is, Chantix is the commercial name, but as you probably all know, Chantix got pulled out of the market. Pfizer had to pull it off about January of last year because of some manufacturing issues that resulted in some carcinogens actually in the tablets. It wasn't anything significant, but they just decided to pull it out voluntarily, even though the FDA, didn't really mandate them to do so. They have not been producing it since then, and I don't know if they'll ever figure it out to produce it in a way that doesn't have those things. We will see. Time will tell. So for now, what we have is the generic version of it that the FDA approved one of the companies to produce, and this is how it works. The reason why it works so well, it's really the best medicine that we have. The reason it works so well, as you see there, it's a partial agonist on the nicotine receptors. So what it does, it sits on that receptor. As you see the red color molecule there, see where the varenicline is pointing to. And then the nicotine is, say, the green molecule. So think about it. This is more of a, schematic way. Of course, not exactly like that, but think of it as the receptor has those two little ports, and then the nicotine comes in and hooks there. But if varenicline is sitting on it, it does not allow nicotine actually to occupy the receptor. And what's interesting is that varenicline, not all partial agonists are created equal, as we say. Varenicline is one of the ones that is such a strongly bound molecule to the receptor that when people smoke, the nicotine from smoking does not displace it. So it's sitting there and does not allow, nicotine to displace it. Now, why that is important? Because at the same time, it's not blocking the receptor, it's partially stimulating it. So that's where the partial agonist comes in. So the person doesn't feel the need to smoke or as much as the craving, because it's just sort of partially, again, stimulating that receptor. At the same time, blocking it from, if you smoke, you don't feel that whatever it is that you get from smoking. So this is a dual effect that it has, what makes it such an effective medicine. And these are the studies so far that are done, and you see 2.24, which is 124%. That's the equivalent of 124% better than the placebo. I'm sorry for the flipping back and forth. Dr. Benvenuti tried to help me here.
Yeah, I'm trying to get the little circle around the 2.24 at the bottom, but it's not working.
That's all right. Don't worry about it. That's okay. So it is 124% better than placebo. Basically, that's the net effect of all the studies. And so finally, before we open up for questions, I want to tell you about the Project Teach, which is where we actually try to reach across the geographic distance, if you wish, and present weekly on tobacco. We present a case, and then we talk about one topic or another as a didactic, and people learn CMEs and CUs, etc. from attending. It's free. Anyone can attend on Tuesdays at noon, and so feel free to join us if you haven't. And then next is the one on the training program, I believe. Yep, that's a certified tobacco program. So if somebody wants to become a certified tobacco treatment specialist, then to join us for a 4-day kind of training, 4.5 days to be exact. And so we've trained quite a bit of people. This is actually, as of last year, I believe 500 so far. Now we're like above 1,000 people trained since we started the program in 2017. And so it's really give people the more finite, if you wish, material and finite information that we don't get exposed to in our usual training. And so there's also 1 day, part of that for 4.5 days, there's 1 day for prescribers, people, physicians, like, APNs or PAs who don't have the time to block 4 days out of their schedule. So you do just a 1 day and learn the prescribing ins and outs. And that's it. Opening up for questions if you have
All
any.
right.
If not.
Thank you very much, Dr. Karam and Dr. Benevetti, for a wonderful presentation. I learned a lot. I'm
That's great.
not a specialist, but I at some point, prescribed Chantix or varenicline, on some patients before, when I was a resident. And
Well, that's good to know. That was our hidden agenda. We didn't tell you that, but we wanted everybody to learn something, right?
but we all know that they are on recall, and so I'm glad there's still generic that could be used, because I look at the data, they have 44% effectivity in 3 months, so they're the most powerful medications right now. And by the way, before I proceed, I would like to thank you and Dr. Benevetti and Dr. Tallo as well, and we will be awarding you a challenge coin, and we'll be giving this to Dr. Tallo as well. There will be a challenge coin in your mail eventually. And for a quick question, we have a bunch of a listener here who are internal medicine students, internal medicine residents, and internists. And of course, we all know they don't have time, to do the integrated tobacco cessation program. What do you think you could advise to them or to Texas Tech regarding on how to, make a institutional integrated tobacco cessation program?
Yeah, well, I mean, this is very important. What Sarah is doing already is starts, but you'd want to have somebody what we were asking earlier about the follow-up, right, with patients at 3 months, at 6 months, and 9 months. It could be a bachelor level person, right, to just call patients and check on them and see how they're doing. That way you collect also your data, what's the impact of your program, if people are relapsing or not, and those who relapse, they could come back, right? That's the minimum and, basic database to collect that data. So the second thing that people can do is if you have the resources or able to, is to try to figure out a way to provide the medications without cost, because even if it's a small copay, sometimes that be an obstacle, right? And they're not that expensive. Actually, the generic ones, the bupropion and the patches and lozenges, I mean, bupropion is like $10, $20 a month. Basically, the patch is like $30 a month. They're very, considering, the cost of other medications, they're very economic. But sometimes patients cannot afford that, right? So especially if we use them in combination, then we get it to like $100 a month. So if you have some money that you could dedicate to, that would be another obstacle that you would remove. And finally, the last thing is to really reach out to patients proactively and not wait for the practitioners to refer them. So I don't know if you caught that, what Dan was talking about, how we reach out, and within Epic, we just get everybody who uses tobacco, we call them and offer a program. And believe it or not, they don't all accept that, even though it's totally free and they don't have to do anything but just agree to try to quit, right? We really get about 60% who say, no, I'm not ready, or thank you, I'm gonna quit on my own, or that my doctor will help me, or whatever. So it's really amazing, how much, people are reluctant or are not ready, even though they may say, oh yeah, well, call me in 3 months, and we do. Right, we just keep following up with them, and so you have to do really a lot of kind of groundwork basically to have a robust program. Right?
Dr. Tallo, do you have any questions for our speakers?
I'm just very grateful, Dr. Karam. So much work to be done, and this is very exciting to me, and I just know it's going to be great, and thank you for your guidance and everyone here today.
Yeah, Sarah is one of our star alumni. I say that because she's really done fantastic. She went out there and really started this whole initiative that we ought to do what we can to support her, right?
Thank you. Yes, please. Everybody help.
So Sarah will be doing an amazing program here, Dr.
Yeah.
Karam. By the way, there are several references that our librarian put in there. You know, these are the reference from your presentation, Dr. Karam and Dr. Benevetti. And there's actually a comment there from Janice saying that probably the audio version is better because you don't need to dress up and put a dress on and put a makeup on. So
Right, that's right. Yeah.
Oh, I would like to say one thing. I have been using ClickSoft, actually. It's a texting platform. It's actually a communication platform. And so I send the link via text. They select the link, then it activates a green button that they select. And then, you know, God willing, everything works well, we appear, but it's actually worked
Great.
fairly well. And it's
What's it
done
What's it
by
called again? What's it called?
ClickSoft, KLI.
ClickSoft.
Click
Q.
QSOFT.
Mhm.
And so for those patients that are older and even not older, it's been pretty successful. And also ClickSoft. And also I communicate with my patients via a business cell phone only. So constant texting after I see them in the hospital and before I see them in clinic, they're able to reach me at any time.
That's very
Questions,
good. That's
can't get their
excellent.
medications. You know, we talk about how they can get their medicines or any problems that they may have had. So that's been fantastic also.
That's really important, really, to give people that support, whether they need to use it or not, but just having that connection is
Yes.
very helpful.
I think this is a very enlightening presentation. I learned a lot from your presentation, and I'm so sorry we are running out of time. But I think as a hospitalist or a surgeon, I think if we have a patient who we know are smoking, we should probably refer those patients to a cessation specialist who could do this integrated tobacco cessation program.
Absolutely. Yeah.
Thank you.
All right. Well, thank you very much again, and thank you everyone for joining us. And join us again next month for another Telemedicine Project Echo webinar. Thank you. Have a good afternoon.
Thank you, Dr. Karen. Thank you, Dr. Benevienti. Thank you.
Thank you.
Stay safe. Thank you.